Good morning, everyone. My topic is very simple but bit complex because if you want to have success and no failures, then you cannot leave anything to chance. And unless the job is done, there are problems at every step. So, in cannulation, after you all have done so much invasive lines and Seldinger's procedure, I think there is nothing new. But there are few warning points which is important in ECMO cannulation. First of all, in ECMO, as you know that uh, e cannulation is the airways of ECMO. If you make a mistake in cannulation, then that is the end of ECMO and the end of the patient. So you cannot afford to make mistakes. You have to be as fast as possible. And you have to be ready for the worst case scenario like ECPR, etc., where you have to even cannulate when there are no pulses. So, given a situation in that scenario, and ECMO is not very uh, common, so therefore you get less chance to do an ECMO cannulation. And ECMO cannulas are the mother of all cannulas, being 27, 29 French cannulas. It is difficult to place a cannula inside a vessel without having any complications. So, giving these points, there are few lead points which I would like to highlight. That ECMO is the airway of cannulation. The important point is the selection of the cannula, the site of cannulation, the cannulation techniques, the complications, and the position of the cannula. As before taking any patient, if there is time, you have to do a ultrasound yourself to understand the anatomy of the patient. The size of the femoral vessels, the size of the superficial femoral artery, and the course higher up if possible to see. All these diameters of the vessel should be there before you, so that it should not happen you try to push a bigger size cannula in a smaller size vessel. So first thing is to do ultrasound yourself. Then there are, of course, three ways in which you can help yourself. First is by your visual palpation. Second is by ultrasound technique, which is a must, that it should be there. The ultrasound machine should be there before any ECMO cannulation. And thirdly, if possible, if ECMO can be done in the cath lab, then it makes your job simpler and faster and more accurate. Then the site of cannulation, as I will go through the process, and as the procedure needs and as the patient requires, the site of the cannula varies from patient to patient and in a given patient from time to time. Cannulation techniques, as you very well know, there's a Seldinger technique, there's a semi-Seldinger technique, and an open technique that I will cover later on. Complication in ECMO, as far as the world literature goes, is around 10%. This 10% is a big complication, and if you are careful, you will reduce this complication rate to 1%. So your alertness, your attentiveness is going to make a big difference in the complication rate. And then ascertaining the position of the cannula after it is inserted is the completion of the job. Who should cannulate? Intensivist should cannulate, or a cardiac surgeon should cannulate, depends upon the policy of the hospital. But I feel who is the ECMO specialist of the hospital, he should be given the first priority to cannulate. Why? Because to gather a team of 10 people all around the patient will take time, and if it is an emergency, then all the people will not be available all the time. So the ECMO specialist or who's taking care of the ECMO department should be given the first priority to cannulate. Then, of course, if the hospital policy to have to put cannula by a cardiac surgeon, it is individual policy, but that is going to waste time. Most staff are given appropriate training for being assistant and third assistant while cannulating, and in the process they keep on learning. And there will be complications if it is done by a intensivist. Then you should have a backup of a vascular surgeon or a cardiac surgeon who is going to handle the complications, because in the artery it is very difficult to control the bleeding when you are halfway through the dilatation and then you are stuck with the problem. Stuck with the problems means what? You have to try to understand this anatomy. This is the pelvis. The femoral arteries are coming like this. Then it deviates 70 degrees and goes to the inlet of the pelvis, and therefore here is the curve. Then it takes a 90-degree curve, and then again it bulges out and goes back. So there is nearly 270-degree curve before the cannula goes up to the biotic bifurcation. So in this passage, there will be twisting, there will be resistance of the lateral forces, and you are likely to cause an endothelial damage. And if the artery is brittle, you are likely to create a retroperitoneal bleed. So this anatomy, though it may appear straight on radiology, but this is not straight. This is the course. So therefore, if you are trying to put a small cannula in a 8 French, 9 French vessel, it's okay, or means 8 millimeter diameter femoral artery. But if it is a bigger cannula, there is no way the cannula will have space for turning and adjusting its distance to maneuver the curves. So therefore, it is necessary that you understand the anatomy and you don't push. I will come to that point later on. Selection of the cannula, as you know very well, that that will be dealt with in practical classes. For arterial cannula, for venous cannula, they are according to the weight of the patient and the volume required for the ECMO perfusion, and therefore the cannula size has to be determined. This is the arterial cannula sizes from 8 French to 23 French, and the flow in ml. So you calculate the flow in ml and determine the size of the arterial cannula. Similarly, the venous cannula. Then these are the cannulation sites, the arterial sites and the venous sites. Most likely it is femoral artery, and sometimes axillary artery, and other sites are uncommon. For central cannulation, you may use aorta. The venous side, most common, it is right internal jugular vein. It can be IVC, and no, sorry, not IVC, the femoral vein. Other veins are also there, but infrequent. So sites of cannulation, we divide the cannulation into two types: a central cannulation and a peripheral cannulation. In peripheral cannulation, it will be Seldinger, semi-Seldinger, and an open cannulation. Open cannulation is mainly for neonates and pediatrics, because you cannot use the femoral site in neonates and pediatrics. So in peripheral VA cannulation, the vessel used are right internal jugular, rarely left internal jugular, right carotid, right femoral, left femoral, rarely right axillary artery, and posterior tubulo-distal perfusion. These are the types of pediatric double lumen internal jugular cannula, or similarly the arterial and the venous cannulas. And there are various shapes and tips of the cannula which help the maneuverability and of course the sharpness also, and the stiffness also. So various companies have come out with the various ideas. It depends what material is available in York City and what you are comfortable with. But of course, multiple hole catheters are now preferred. So of course, the general principle as usual, you have to prepare the site, maintain sterility, anesthesias, paralysis or local anesthesia and anticoagulation. All those things are the standard format for putting any cannulation. Now we go ahead with the Seldinger techniques. In Seldinger techniques, important part is that once you take a puncture and if you dilate the vessel, you create a spasm all around. So in Seldinger, I would like to take all the 3 punches at the same time. So if it is a right VA, right femoral vein or right femoral site VA ECMO, I will use 2 distal two retrograde punches, one in the vein, one in the artery, and one antegrade puncture, one in the right femoral artery at the same time. Put all the 3 wires at the same time. This is to prevent that some spasm coming, or once you dilate, then you find the other vessel is behind that cannula, and then you're difficult to dilate. So when the vessel is well palpable, there is all space, the area is neat, there is no swelling. So at the same time, take all the 3 punctures. Once you take the first wire inside, give heparin, 4000 units of heparin. And once all the wires are in place, then you start dilating. First the vein, then the artery, then the ECMO to be activated, and then the antegrade distal limb perfusion on the ipsilateral limb for distal perfusion. So take all the 3 wires together at the same time and then do serial dilatations. Now I was talking about the imaging. As you see, this is a real-time image of the position where you exactly want to cannulate. So this is the point above the profunda femoris. That is the point in the femoral artery at the head of the femur bone. You would like the needle to puncture there, and then you put the catheter inside, because if you puncture lower down, the vessel caliber may be abruptly small, and therefore it may find difficult to dilate the vessel. If you see on the next view, that you saw in the AP view, but in the lateral view you can see the course of the vessel. So the course of the vessel is not at all straight, and this is how from the inlet of the pelvis to the sacrum bone, the vessel takes a tortuous course, and therefore you have to be very much mindful about the size of the vessel and the cannula you are using for dilating. This again in the oblique view, you can see the course of the vessel. These pictures are all real-time images from CT scan department, and they show you the course of the vessel. So therefore don't take femoral puncture lightly, because you may end up with retroperitoneal bleed, or maybe you may cause a dissection, or you may land up into aneurysmal portion, or there may be a friable atheroma there. So all those things are possible in old age, and this is the course of the vessel. So even Seldinger technique is a blind procedure, and not only the puncture site is important, as you course the vessel with the dilator, you have to see that this is the anatomy, and therefore you don't push your luck. Very important is that once you take a prick, see that there is a good backflow, whether in the syringe or otherwise in the artery, a very good backflow. If you are not happy with the backflow, don't even think of putting the wire. You may puncture the vessel 5 times, does not make a difference. That is a needle prick. It will be easily controlled with compression. But if you think you have to pass a wire, and if you pass the wire in a small vessel and then the vessel causes a hematoma inside, the wire causes a hematoma inside, you lose things beyond your control. So if your prick is not good, do not take 5 attempts. If you are not possible, call a vascular surgeon. But if you don't find a good backflow, don't put the wire. Once you put the wire and you find there is no easy movement, no free movement of the wire, don't dilate the vessel. Because if the wire is finding resistance, that means it may be in a small vessel, or it may be some intimal or whatever. The wire should also be moving freely. Once the wire moves freely, you have to put the wire distal to the parking place of the catheter. If I have to reach the IVC RA junction, my wire should cross at least up to the SVC or in the RA, so that I am sure that I am not meeting with some congenital anomalies of the great vessels. So therefore I may not land up into a problem later on. Similarly with the dilator also, the dilator may go, the wire may go into hepatic vein, renal vein. So you should not even think of putting the cannula unless the dilator has gone through and through in the entire course up to the distal parking place. And once you find the distal parking place on Ziffy sternum ultrasound well within an IVC or aorta, wherever you want to position it, unless you have confirmed that position on wire, then only attempt to dilate. Once you dilate, it should be a smooth dilatation. If you are finding a resistance, you may think of changing the size of the cannula, and once you have done that, then only put the cannula inside. So this is just to show you, though it appears straight, but this course is not straight, that I showed you very clearly. And these are the positions of the various landmark positions, that what is the femoral triangle, what is the femoral sheath, and what are the femoral vessels inside, and how they are positioned. So therefore, you look at the inguinal crease is something different, which according to obese patient shifts down, but the inguinal ligament is way high up. So therefore, try to be out of problems. So try to go below the inguinal crease so that your abdominal fold is not interfering in the process of dilatation, or you need somebody to hold a heavily obese patient. And this is the course, this is the relation between an inguinal crease and an inguinal ligament. And as I said in this vessel that you have to, the red color thing, the profunda femoris, you have to have the puncture above the origin of the profunda femoris up against the head of the femur bone. So as I said, we need to take 3 punctures, one in the artery, one in the vein, which is retrograde in fashion for the ECMO circuit, and one in the antegrade fashion, which is for the distal perfusion. One is above the inguinal ligament, 2 are below the inguinal ligament. All 3 punctures, one is from the abdomen downwards, and 2 are from the femoral sheath. And then they have 2 are below the inguinal crease, one is above the inguinal crease or inguinal ligament. So all 3 wires to be taken like this. If you have to take more punctures because of more cardiac output required, you may use the other way groin also. And then the fixing. The fixing is important. Once the patient see a very nice way of neat way of doing things, and then you have a curvilinear process of securing the cannula so that it does not cause a direct traction. So stay suture should be in a slightly curvilinear manner so that the direct force is not transmitted to the puncture site and does not cause back bleeding. Then you have to confirm the position on the cannula that the IVC, the SVC cannula or IJV cannula is where, the femoral vein cannula is where by radiology. This is just the radiology pictures to show the confirm the position. Then for axillary artery dissection, this is just to show you the pictures, but this is a bit related with complications because it tends to bleed, and good hemostasis cannot be achieved here. And this is for distal limb perfusion where you are putting the antegrade perfusion. This is here done below the femoral sheath. We usually prefer it above the inguinal crease. And this is just a femoral vein cannulation being taken. This is the puncture for the IGV catheter. Now semi-Seldinger technique. In semi-Seldinger technique, it is the same as Seldinger technique. All the armamentarium are the same. Only thing, you are not puncturing the skin, you are puncturing the subcutaneous fat. So you require all the same thing, but the only thing you are doing it directly under vision. You have stabilized the vessel, and then the procedure is the same. You don't nick the vessel. For semi-Seldinger technique or a Seldinger or a open technique, let us divide into veno-venous ECMO and veno-arterial ECMO. Because it is only the neck lines which are available for pediatric cases. So a double human cannulation for a right interlude, again, the patient, these are the steps. You prepare the patient, you take a transverse line, a cervical incision, you have proper cautery machine, you divide the platysma muscle, retract the sternocleidomastoid. Division of the omohyoid may be required, may not be required. So this is just a process to show you that you have divided the sternocleidomastoid muscle, and you are trying to expose the blue color structure, that is the internal jugular vein behind the omohyoid, and you have exposed the vein, and you are going to directly take a nick there. The material is the same, the double lumen catheter and the dilators and the wires. This is a transverse skin incision below the sternocleidomastoid division, and in the suprasternal notch about 1 to 2.5 centimeter above the clavicle. Then you make a neat dissection, try to expose the vein. The vein is very visible there, and you only dissect the anterior wall, keep the other thing fixed properly with the fascia all around. Measure the distance, how much distance has to be introduced, the cannula has to be introduced to reach the SVC-RA junction. Then you can take a needle prick also. You can stab, dilate the tract, use a guide wire, use 5 French sheath, and give heparin. Then after the puncture has been taken, you just take sutures and stay sutures for the cannula, and then put it properly. After this, the main work is not here. The main work is at the head level, because the neck is short, and with slightest movement of the neck, the cannula can move 1 to 2 centimeter in and out. This movement of the cannula is going to put the tip into the RA. So for that, a good fixation is required. So after you have placed the cannula properly, you have secured the double lumen cannula for this thing, and you have taken the controls. The lumen size is this much. The artery size is 1/3 of the venous side, because that comes with the force. Then the open technique for VA ECMO in pediatrics. Again, just want to show these pictures for the neat job. Please try to, the thing is simple, but how people do it properly, we have to just see an example. This is a double lumen VA ECMO cannulation in a pediatric patient. Same steps as you have been doing it, but because this is an open technique, you have to ligate the carotid artery. So therefore, this becomes an open technique. The same way you take the controls, take a transverse incision in the neck, 2 centimeters above the clavicle muscle, below the level of the sternocleidoid medial border, and you retract the sternocleidoid muscle laterally, give an neck incision, same distances. Now you have seen both the artery and medial vein, both are very well visible. This is the internal jugular vein, this is the carotid artery, and this is how you take controls with good dissection, the common carotid artery in the internal jugular vein. Then you do the arterial sizing, how much distance the cannula has to go inside, and accordingly you position the cannula accordingly. Then you take the plagets to take the control on the distal or the proximal side of the, distal side of the carotid artery, so that there is no back bleed, and you ligate the carotid artery being ligated. Then make a small transverse incision in the carotid artery. The carotid artery is open, and you pass the cannula in the carotid artery. With plagets, take sutures, all that being done, 1 sutures, 2 sutures. Then take care of the IJV, extend the length to connect to the ECMO circuit, do a de-airing, take proper controls. The venous thing also done, clamped, venous side open, venous extension taken, arterial was already taken previously, do de-airing, skin closure, proper controls. Yes, this is very important slide. There is no holding, or there is no way to control the torque applied by the movement of the length of the tubings, which will displace the cannula like anything. So therefore, you have to secure the cannula also at this point. Sorry, I would like to suggest, yes, at the word caution there, you see that Dynaplast being applied there. So neck is not important. The torque from which the tubings are getting connected to the cannula, that should also be in proper control, and you should stop the force there. The force should not come right up to the level of the cannula, so it get displaced. So a proper positioning is very important. So though you may feel that cannulation is just taking a puncture, the job is not that over. The job is still continues. It continues till the ECMO is completed, and therefore you have to be mindful, because small things, if not attended properly, is going to create a problem. So then forward ahead, this is just an open This was the about peripheral cannulation. This is the central cannulation. This is the post-cardiotomy patient, and this is the central ECMO cannulation. Bleeding is a horror here, but this is the way it is. Either you take a RA to aorta cannulation or other types of cannulation. So these are cannulation in the theaters and the ICU, but that is a very complex things, and this comes under the domain of a cardiothoracic surgery department to manage these patients with all these tubings and the bleeding and hemostasis and of course infection and sepsis. So this is the position of I told you that the third part was the open cannulation, and then of course, and as I said, once the cannulation is done, the entire length you can see again securing the cannula is not only important, the tubing is also very important. So the tubing does not apply a torque on the cannula, and you have to secure it very properly. So central cannulation via transthoracic approach has advantages and disadvantages. Advantages that it requires minimal additional dissection, the very good drainage, it improves the cerebral perfusion, and it increases the venting options. But it causes increased bleeding, and there is a decreased respiratory function. Cannula are likely to dislodge, and infection, of course. So there can be a VA ECMO from RA to aorta, commonest form of central VA ECMO. Then there are many other options available. This is the central picture to be shown. All these A, B, C, D, E, are all the possibilities and combination which can be done from pulmonary artery to aorta, or RA to aorta, or from directly left ventriculotomy, or right superior pulmonary vein to aorta. All this combination can be done depending upon the surgeon's preference and the surgery they have performed. And this is just to show you the left ventricular venting option from ventriculotomy in case to have a knee dissection if the patient was not an open chest. So now venting options, there are all these types of possible venting options from pulmonary artery to LA to LV to RA and to aorta, and there are various catheters available now for LV venting because that is gaining popularity as VA ECMO is increasing. So the most commonest venting option was VA ECMO plus IABP, then VA ECMO plus Impella, and then VA ECMO plus LA drainage. So these are the commonest type of good options for venting in a VA ECMO. These pictures are telling IABP. This is telling about transeptal puncture and the pigtail catheter there into the LA for LV venting, LA venting, and of all the possibilities, they have the effect on the hemodynamics, on the clinical and radiological pictures, and which mode, which position, and which technique. There are many options in that manner. Okay. Now then, distal perfusion. Distal perfusion, as we said, that the ipsilateral limb, because of the spasm around the artery, is likely to get ischemic. So therefore, we have to put something in the antegrade fashion to have a distal limb perfusion. There were simple catheter introduced a sheath, 6 French or 7 French. I said passed antegradely above the inguinal crease. But now newer cannulas are being designed, and this cannula has got a side port like this, which after introduction has got a lateral opening, and whatever is returning also going bidirectionally, 90% forward and 10% backward. So it may not require a distal limb perfusion. That is still experimental, but it appears promising. So this is the same biflow cannulas are available, which will show that the blood will flow in both the directions. So other options is to have a reconstruction. You do a open technique, and you put a Gore-Tex graft by the end to side communication from the vessel, and in that Gore-Tex graft, if you can suture the cannula, so the cannula will not cross the main vessel, so it will flow in both the directions. So bidirectional flow by putting a Gore-Tex graft is another option. Then there are other newer cannulas which are available in the market. One is the Avalon, which you all have heard about and seen, but very few are being able to procure it. Then the double lumen catheter, the jugal double lumen catheter. This is the Avalon cannula, in which the blue port drains from the SVC and IVC, and the right port gives it back to the tricuspid valve. These are all avenol cannula. Then this is the lava catheter. The lava catheter drains from the LA and also from the RA and also from the IVC, and therefore it also causes a decompression of the LA by doing an LV venting, and also takes the blood from the RA and the IVC. So therefore it does a triple job of unloading the left atrium as well as taking the venous return from the venous side and giving it back to the artery. So this is the lava catheter. This is direct ventriculotomy, just in the case of a knee dissection, and then sometimes they pass a catheter from our LV apex right across the aortic valve into the aorta. So if the LV is not ejecting, instead of just sucking the blood from the LV, they can return the blood into the aorta from this side also. Now this is the VPA catheter, or the IVC pulmonary artery catheter, in which if the RV is failing, you can bypass the RV and place the catheter to support a failing RV. These are the other types of cannula available, and this is the circuit made arrangement with a pump and a oxygenator for a VPA catheter, so that you can see this is how it functions, similar to an impeller circuit. It takes the blood from the RA RV and pushes it back into the pulmonary artery, thereby bypassing the right ventricle. Okay. Then of course the imaging, once you put the cannula, you need to see the things are proper. So you have to imagine that how much part of the catheter is radio opaque and how much is radiolucent. If the so nowadays the wires are corrugated, or there is a steel braiding right up to the tip, so the catheter is seen tip to tip. If not, few cannulas in the past, which is a 4 centimeter area, which was only plastic and no metal cap, has to be imagined like this, whether the catheter is too deep inside or how it is. You see the catheter too deep inside with the cannula position, and this is the normal side of the cannula position. Then again too deep a position, then too high a position, the arterial cannula is too higher up, then the arterial cannula too low, that is both cannula are too low. So therefore all those things can be seen, which will change every day with the position or with the baby care or otherwise. So these positions need to be confirmed on chest X-rays every daily. So otherwise cannulation is not free from problems. There are very common complications like bleeding, infection, cannula malposition, injuries, vascular thorax, retroperitoneal bleed, tamponade, perforation and dissections. So there was a study in which they showed from 1992 to 2000. That time VA ECMO was not very popular, and then they showed that 31% of inotable respiratory cases had a problem, 26 pediatric population, 18% adult cardiac percent problems. So average 9 to 10.1 cannulations per surgeon was the complication rate, and therefore they say an average 10.6% complication rate is a higher percentage. So therefore we need to improve our technique and our attentiveness in cannulation to prevent complications. Thank you. Any questions? This was only just because I would not be able to speak all these points to all the batches, so I made it bit lengthy, so all these theoretical questions are out. Then we only concentrate on cannulation when we reach the table. Any questions, please? Yes.
Sir, you mentioned about placing a Gore-Tex graft for a femoral artery cannulation so that it will support our distal perfusion and forward flow. So how well is it practiced? I mean, what is your experience on that?
See, surgical institutes, they are more used to doing it because that is an exercise for them, and therefore instead of having a friable endothelium and a messed up tunica media and other things in the vessel wall after 1 month, 2 months of cannulation and then reconstructing the artery. If they use a Gottes graft, they will spare the artery. So I do not have a vast number to tell you that how many people are practicing it. But of course, if you want to have a bidirectional flow and to protect the vessel, this is practice. This has been tried by, at various centers, and it appears to be promising.
Thank you, sir.
So the serial dilatation has to be done in any order, sir. You told 3 guidewires will be in. So
Yes, first the vein, because vein is a more friendly structure. So even if you have a blood in the vein after cannula, inside the cannula, and you take another 5-10 minutes to dilate the artery, the vein will tolerate the blood better, and there's nothing like a big spurt, so you will not have much blood loss, and you can see the JVP of the patient by seeing the column of the blood moving there. So first the vein always, then the artery, and once both the things are in place, immediately connect it to the ECMO circuit, starts the flow, reach 2.5 liters, position the artery and the venous cannula properly. Once you are comfortable, then put the distal perfusion into the sheath.
So you told the femoral artery takes curvature. So while putting the femoral arterial cannula, do you have any maneuvers to overcome those curvatures, sir?
See, as such, once you are dilating, particularly obese patients and females, they have a narrow caliber vessels. So unexpectedly you are faced with more spasm, or you find the cannulas or the dilators are stuck. You are aiming at 27 and at 20, say 23 or something, you are stuck. Then and the cannula is not moving freely. Then do not aim for 27. Only be comfortable with 23, so that you do not cause intimal injury. Otherwise, there is no obvious. You can try and nitroprusside, or you can try nitroglycerin to be given to dilate the vessel, but I don't think so that vessel is going to dilate in a big way. But you can try that out. The only thing is you accept a lower size.
Sir, in obese patients, are you able to see with transthoracic echo, sir, the guide wire? Suppose patient is very obese.
Epigastric window is very good, even in an obese patient, so it does not cause a problem. And of course, again, the vascular Doppler is good enough with 8 to 12 hertz frequency to show you the femorals. So even in an obese patient, you get to see the vessels properly.
So not the femoral, sir. Suppose post-abdominal surgery.
Yes.
The subcostal window for seeing the guide wire is a little bit difficult.
Yes, there can be individual problems. If you are not able to visualize, take the patient to cath lab. There are situations where you don't get a window. If you don't get a window, if possible, take the patient to cath lab.
Sir, dual lumen cannula is available for adults also?
Available in Europe, but not available in India at the moment.
So we are using double cannulas only, like.
Yes.
Thank you, sir.
So after lava ECMO, will there be a ASD once you remove the?
Yeah, there will be an ASD. I feel that ASD is you can say a blessing in disguise that will still continue to decompress the LA.
Oh,
so,
okay.
and that ASD is not really going to cause much hemodynamic embarrassment to the patient. And because it is a neat surgical incision, over a period of time that is going to heal.
Okay, sir.
it depends upon the experience of the vascular surgeon, and definitely it is a right angle uh, junction. It has to be secured properly. Probably that job was not done properly, in which the end to side communication was given a proper support, and therefore it hurt the vessel, or the sutures gave way, so it caused a bleeding. But if properly supported, it should not. Uh, Maybe, yes, or maybe the vessel condition was friable. Something on the one side has given way. Other things, as we are getting late from a hands-on experience, we will just demonstrate a central uh, demo for a double lumen venous adult Avalon cannula, to show you that how we tend to progress. So, Dr. Ojha will be taking the puncture and doing the dilatation. I will be showing things on ultrasound. Jelly, jelly. Okay. So, you can see the vessel in a enlarged view. The color is seen in the vessel, and there are the outer wall and the inner wall. I will go out of plane and show you a circle. Okay. Okay. So, on the left hand of the screen, you can see the circular structure, and this is the vessel. Now, if Dr. Ojha, you can start. You can see the indentation by the needle. Okay. You can see the backflow. As it pushes the wire, you can see the wire movement. Okay. You can see the wire movement. Yes, proceed, proceed. You can see that is crossing the IVC now, and okay. So the wire is in place from interjugular vein to SVC to RA to IVC. Now serial dilatation has to be done. You may take a nick, you may not take a nick. All depends upon the resistance you encounter. मोटर बंद कर दे, मोटर रुक जा रुक जा. He used a 8 French dilator, not a 12 French dilator. चालू कर दे. The dilator you can see is crossing the IVC RA junction. Yeah, in Avalon, as you see, this is Avalon cannula. This is blue in color because it courses through the venous channel. These are the IVC port. Yes. This is the double lumen cannula. This is the IVC holes. This is the SVC holes, and these are the holes for the tricuspid valve opening. The blue color dilator is meant to be in the venous side. The red color is for the returning side. The returning side is joined to the tricuspid valve orifice, the red color port. The blue color is draining simultaneously from the SVC and the IVC, and this has to be kept at 12 o'clock or 2 o'clock position, so that the tricuspid valve orifice, the holes on the cannula faces the tricuspid valve orifice, and this dilator has to definitely be in the IVC to have these holes in the IVC. Arterial at 12 o'clock or 2 o'clock position. इस तरफ आ जा.
So it has to be holded like this.
कैमरा.
कैनुला दिखा. पूरा पूरा. मेरा हाथ दिखा. ऊपर वाला.
इधर आगे आगे गया. ओके.
So this port.
This red color port has to be medially 3 o'clock, 12 o'clock to 3 o'clock position, and as it pushes it, it goes beyond, and you can see the dilator coming to the IVC, and the holes. One second, again, if you see at the holes, these are the IVC holes. This is the tricuspid valve hole. This is the SVC hole. The IVC holes here has to be at the IVC RA junction, and machine band. The model size is slightly smaller to the adult human size, so therefore these cannulas are remaining slightly out of place. But then of course the tricuspid valve, these are the opening for the tricuspid valve, they should be coming at this place, and this here is the SVC holes which should be remaining in the SVC. So this is how we position the cannula. The cannula position can be at 12 o'clock or 2 o'clock, and that has to be confirmed once we restore the flow and connect to the ECMO circuit. You see a very good flow from the tricuspid valve orifice to the tricuspid valve. The orifice on the cannula will show a 3 to 4 liter of flow moving into the tricuspid valve, so you will have a good color turbulence. So that is how you position the cannula, double lumen VV ECMO adult cannula Avalon in this position. Simple cannulation procedure will do it on bedside at table side. So anything particular about? It's only one height available. Not that there is a different diameter, but not a different length. Yeah, even if I am slightly above in the RA or slightly above in the SVC, but my tricuspid valve orifice on the cannula should be facing the tricuspid valve.
The tip should go in the hepatic IVC. So once the tip is in hepatic IVC, rest everything is going to place remain in the place. Okay. So you have to just keep a probe. If you are not doing under fluoroscopy, you just keep a probe and see that the tip of the cannula enters the hepatic IVC. It just crosses the RA. The moment it crosses the RA, rest everything is placed. Okay. If the height is small, in that condition also, the hepatic, probably the cannula might go a little more in the hepatic IVC. That's fine. The hole has to be facing the tricuspid valve, and the SVC part should be in the upper part of the RA or SSV. That's it. Yeah, ideal best is fluoroscopy. But if patient is not in a position to be shifted, you can do it under transthoracic or transesophageal also. Yes, that is a common thing that can happen. Usually what happens is